Hello, everyone, and welcome to our very first episode of the Gaining Health podcast, where we are revolutionizing healthcare with obesity medicine. I am your host, Karli Burridge, and I am so excited and honored to have our very first guest with us this week. We are talking to Dr. Angela Fitch, and I honestly could not think of a better person to kick off this podcast with. And let me just tell you a little bit about her in case you're not familiar with her, but if you're in obesity medicine, you're probably very familiar with her. But Dr. Fitch is the Associate Director of the Massachusetts General Hospital Weight Center and faculty at the Harvard Medical School. And she's board certified in obesity medicine, internal medicine, and pediatrics. And she began the practice of obesity at the University of Minnesota, treating children with obesity. And in 2012, she became board certified in obesity medicine and has been treating obesity full-time ever since. And since then, she's moved back to Cincinnati to create a multidisciplinary medical surgical weight center and is currently serving as the president of the Obesity Medicine Association. So welcome so much, Angela. I'm so excited that you're here with us today to kick it off.
Thank you, Karli. This is wonderful that you're doing this for everybody. It's great. I'm honored to be here.
Good. I'm so excited to have you here, honestly, because you're not just a wonderful leader in this field, you're a wonderful speaker and you speak with so much compassion and you have just so much knowledge. So you have so much to teach all of us. So let's start with this, because a lot of people, when they hear obesity medicine, do you ever get funny looks when you say you're an obesity medicine specialist or when you talk about obesity medicine and people are like, what is that?
Exactly. Or it's not very fun at parties either. You know, when you tell people they say, what do you do? I'm like, I'm a doctor. What kind of doctor? Oh, I'm internal medicine pediatrician. Oh, you do primary care? No, I do obesity medicine now full time. And they're like, oh, I don't normally eat this way. It's like the first thing that comes out of their mouth. It's like, because you had a party, it's holidays, whatever, you're celebrating, you got a plate of food that you're usually standing there, and a drink in your hand and you're chatting with somebody, So it is kind of a little bit of a, you do have to kind of explain it, I feel like, to people.
Yeah, it can be a little bit awkward at times. So can you explain to those people who are still kind of like, what exactly is obesity medicine and what does an obesity medicine specialist do? Could you go into that a little bit? What is this field about and what do we do in our day-to-day?
Yeah, so I think it is as you know, a growing field, right? One of the fastest growing medical specialties that we have because of the number of people that need care, right? We have 115 million people with obesity in our country, and because of the prevalence, and now that we have even more effective treatments, I think people are, wanting to access actual obesity medicine, right? Which is the care of the person with obesity in terms of helping them to reverse that disease process. So if we believe that obesity, which is defined as the storage of excess body fat that may be affecting your health, right? Mm-hmm. So you're storing excess adiposity, potentially inappropriately or potentially, for some dysfunctional reason, right? That's what we believe, that the disease part of it is what's dysfunctional. Right. And so because of that disease, you have this excess adiposity that's then leading to things like diabetes, things like elevation in your blood pressure, sleep apnea, arthritis, all sorts of heart disease, right? All sorts of complications of having that excess adiposity, the excess fat storage. So I think that's what, obesity medicine, we focus on how do we reverse that process? How do we treat that process effectively so that you can accomplish your goal, which is to lose that excess weight or that excess fat that you're storing, inappropriately. And that's the clincher, right? Is trying to make that happen, because I tell patients all the time, it's not normal to lose weight, right? Weight loss is not a normal human process. And so to do something abnormal is even harder than trying to do something normal. Most of the time we have abnormalities we're trying to fix, right? Abnormalities in my blood sugar, that I'm fixing, right? So I'm trying to become normal to reverse that disease process. But in this case, losing weight is something the body fights against. So as obesity medicine physicians, we're trying to optimize that however we can for that individual person to try to reverse that disease process.
Right. Yeah. We're biologically designed to protect ourselves from weight loss, right? Because if we think about for
Right.
millions of years that we've been roaming this earth, the vast majority of that time, starvation was a major threat to our survival, right? And it's interesting. I'm
Exactly.
watching this show right now. It's called Alone, where these people are out in the wilderness and their primary concern is to get as many calories as they can and to conserve as much energy as possible. And that's how we're all biologically have evolved, right? And now we're in this environment where that's really working against us, right? So it's just so challenging. So, what do obesity medicine clinicians actually do to help treat obesity? Like, what are some of the pillars of care that providers can use to treat patients with obesity and pre-obesity?
Yeah, so as you're well aware, being a very integral part of our Obesity Medicine Association for many years, I think that, what we try to talk about are those pillars, which is a nutrition, physical activity, behavior, or lifestyle change, right? And then, using a medication, or some sort of a device or some sort of a tool, including surgery, to help patients gain that result, right? Like any disease, it's multifactorial. We don't just treat hypertension with only diet and exercise. We treat it with medications as well, especially if it's severe enough that it needs that treatment, right? That those risks of health are such that using a medication is gonna be necessary, right? And same with surgery. I mean, people have open heart surgery for blockages in their heart. It doesn't mean that they don't they focus only on eating better and exercising in order to get rid of that heart disease. They take medication for it, they might have surgery for it, and they also do this lifestyle approach, stress reduction, healthful nutritional behaviors. All those things are things we all have to work on because the environment that we live in today is not producing wellness, right? It's not producing a state of well-being. It's got too much stress, too little sleep, too many calories, too many empty calories or processed calories, and not enough physical activity. So
Right.
all those things are things, all those pillars are things we should be doing regardless, just for the health of it, not necessarily for the weight of it, right? But just to be healthful in our lifestyle. And we have to work at that because the world we live in is opposite of that today.
Right, right. And especially for those people who have the genetic predisposition to put on more weight. Again, everybody's a little bit
Right.
different, right? There's so many individual circumstances, different genetics. Everybody has their own different journey. So hearing the patient's journey and what could be contributing factors for that individual person, right? Might be weight
Mhm.
promoting medications also, or things like that. So
Right.
when you're talking to patients, and I love it when you talk about this at conferences because you have this awesome pyramid slide that you use when you're helping to talk about how you know which treatment option to choose for which patient. So can you go over that a little bit? What does that conversation look like when you're talking to a patient to try to determine, which treatment options might be right for that individual person?
Yeah, so I think it's very important that we start to use what I call shared decision making in our discussion with an obesity treatment. Because, like any other disease, there should be a shared decision making process, which is the process of saying, what are you looking for in your treatment? What is your goal? What are you trying to accomplish? And for some people, they're trying to accomplish a certain amount of weight loss because they have to have their BMI under a certain number in order to get knee surgery or in order to get hip surgery or to get a transplant, like something as significant as that, where other people might want to just be preventing a disease, right? They might be wanting to prevent themselves from getting diabetes because their whole family has diabetes and they don't want to get it. So we know that different levels of treatment, to reach those different states, you need a 5% weight loss, for example, and you need to maintain that 5% weight loss in order to long term prevent the risk of diabetes, prevent developing diabetes. But to reverse diabetes, you need more like a 15 to 20% weight loss. So if you have diabetes and you want it to go away, you need to get even more weight loss. And we know, according to our sort of pyramid or pillars, whichever way you want to, if you want to flip it on its side or you want to put it up and down, but the
Right.
idea is that you move throughout this journey, um, you know, employing these different treatment interventions, not because you want them. Like nobody wants surgery. That's what I tell patients all the time. Like people come in and say, I don't want surgery. Well, I don't want surgery today either. Like, I mean, but if I have to have surgery because surgery is going to produce the best outcome for me, then that's what I'm going to choose to do because I need that 20% weight loss, 30% weight loss, that until recently with some of our newer medications, it was very hard to achieve a 20 to 30% weight loss without surgery. And even today, it's going to be hard for even 40% of people to do that, even with our newest, greatest medications that are coming out. There's still 40% of people that can't get that 20% weight loss with medication alone, which is not uncommon with other diseases. Like I said, you can't just reverse your artery disease in your heart by eating better and exercising and taking a statin. You need to layer on top of that having potentially a procedure done or having a surgery done, in order to make those things better. So that's all, again, that complicated interaction, and having that discussion though, and that realistic expectation that lifestyle intervention on average produces a 2 to 5% weight loss, which is great. I mean, for everybody to do. But if you need more than a 5% weight loss or more than a 2% weight loss, you're probably going to need to increase your intensity of treatment, right? And add something else, add another layer on top of that. And that's what we don't have to wait till we fail this other treatment, right? Because it's not about, people take it very personally that I failed, because I didn't lose 20% of my weight, with diet and exercise alone. When we know that only about 4% of people are able to do that. Only about 4% of people can lose 20% of their weight with a intensive lifestyle intervention. And but the person feels like, I failed somehow because I wasn't one of the 4%. I mean, most people, are ecstatic if they're even close to one of the 4%, right? But people, we have this misconception because of years and years of people saying, just eat less and exercise more and you'll be fine, right? And so there's this over focus on that one treatment versus employing the whole spectrum or the whole pillars of treatment.
Yeah, I agree. And I think what you said is so important is people have this expectation because that's what we've heard all along. And those are the stories that we hear. Somebody loses 100 pounds and those types of things with lifestyle changes alone. So that's what people expect is going to happen. So that's where I think it's so important that we really hone in as you do, saying that, yes, some people can achieve but it's only 4%, right? So when we're thinking about it from a medical provider point of view, would you really recommend a treatment that only has a 4% success rate, right? Or would you be looking at other treatment modalities, on top of that?
Right.
And so, really, understanding obesity as a disease, understanding the pathophysiology, and then treating it just like we do other medical conditions where we do intensify treatment as needed. And as the severity of the disease gets worse, it's the same thing, but it's just really changing that mindset that obesity is in fact a chronic disease and that lifestyle changes alone are not enough for the vast majority of people. And sometimes I think about it in terms of skin cancer too, right? Like, yes, put on sunscreen to prevent skin cancer. Sunscreen is kind of like the lifestyle changes. So like, yes, it's good to do. Everybody should do it, can help prevent skin cancer. But once somebody's developed a melanoma, you're not going to tell them to just put on more sunscreen.
Right. Stay out of the sun. Don't go outside.
Right. Exactly. So
yeah,
that's absolutely right. So I want to switch gears a little bit and ask you specifically for you personally, how did you get introduced to the field of obesity medicine? How did you get involved? Can you tell us what that was like? Because I feel like everybody always has such a interesting story and how they got there.
Yeah. So I was very much, even, as a medical student and resident, I was just very interested in metabolic health and metabolic syndrome and weight management and diabetes and all these sorts of, sort of metabolic diseases. They just fascinated me, I think, because I'm an engineer by undergraduate training, chemical engineer. I was always into how does the body work chemically, right? And how does it keep itself going and all these sorts of things. So I was very, just interested in that. And then, patients coming in, being in a busy primary care practice, I'd have patients all the time, coming in for their physical going, I want to lose weight. Like, how do I do that? And I'm like, oh, I don't know. We didn't really talk about that in medical school.
Right.
Right. So I was like, well, you could eat less and exercise more. There's several ways of doing that. And so it's really what I would sort of like, the best I could do. And I thought there's got to be something better than that. So I really started to just, read on my own. And again, this was before the time when we had an official, official board certification, but the American Society of Bariatric Physicians, which is now the Obesity Medicine Association, right, was around. And so I went to a conference, right? I said, oh, I'll go to this conference and I'll learn about, this thing called bariatric medicine at the time, right? Was what we were sort of, calling it or referring it to it.
Yeah.
And so I started just, learning on my own and going to these types of conferences. And then I started to just practice it. So you mentioned in my bio that I started seeing patients. Actually, I started my obesity career doing pediatric weight management, which was sort of, a little bit unheard of at the time. It wasn't quite as prevalent, back in the early 2000s as it is today even, right? But we had a very busy pediatric weight center at the University of Minnesota. And one of my colleagues knew the person who ran it, Sarah Jane Schwarzenberg. She was a gastroenterologist, is a gastroenterologist still, and she was running the pediatric weight center. And they needed clinicians to see patients because there was such a backlog, even back in, like I said, 2008, 2009. There was a backlog of patients and they couldn't get through them all. And so they needed people. And I volunteered myself and I said, oh, can I go, see patients half day a week? So it's sort of like on the job training, to be honest.
Okay.
It was like a see one, do one, teach one
All right. So they
type
were kind of
thing.
doing some of that already at the
Mhm.
center where you were.
Yeah, we had a dietitian. We didn't have at the time we didn't have a psychologist. We had a dietitian, and it was the physician. A lot of the one of the physicians was an endocrinologist by training, and again, he just had an interest in it, in terms of weight management, and in that time, I mean, we really had some metformin. We had the dietary approaches, right? But we did the first study actually of GLP-1 in pediatrics back in 2007
Really?
there at the University of Minnesota, when we started learning about the effects of GLP-1 on weight control and weight management. In adults, obviously, is where we first recognized that there was, this sort of benefit. But we there at the University of Minnesota translated that into a study of using Byetta at the time, because that was the GLP-1 that we had the most access to.
Yeah.
And we studied that in adolescents. So we did the first study.
Wow, that's
Doing that.
fascinating. So even back in 2007, that's really wow, that was very new for that time, especially since obesity wasn't even recognized as a disease yet at that time. And so that's
Right.
really exciting. And so you've kind of seen it all the way from the beginning all the way to where you are now. So what are some of the things that you're seeing now that get you excited about this field? And obviously a lot of new medications and things coming through the pipeline. So what do you think the future is for obesity medicine?
I definitely think the future is very bright in that, we really are at a cusp, as you mentioned, that, in 2013, the American Medical Association declared, said obesity was a disease. But even then, it's still been a struggle, these past 10 years or so, really, sort of getting it across to patients, across to society, right? That it really is more than, it's going to take more than just eating better and exercising more, to be successful with this disease process, just like any other disease process. Lifestyle is a component, as we mentioned, but it's not the end all be all. It doesn't create the most effective treatment in most circumstances. It doesn't mean you don't do it, because we all should do it for the health of it, not necessarily for the weight loss of it. But as we're talking about weight management, we really have to get into these other modalities of how do we actually give ourselves as human beings a metabolic advantage towards weight loss, because right now we have a metabolic advantage towards weight gain, because that's the way we're engineered. And so I think, we're learning more and more about that today with lots of different medications that are coming down the pipeline. And I think it's very exciting, because there's going to be even more ways of helping people understand that. And I think society is really coming around to that, right? Society is really understanding that it is a quote unquote real disease, and making some progress there. But it's very slow progress, right? We really have to, we as clinicians in the field and as patients too, need to sort of stand up and say, like you said earlier, why would we accept insurance companies a lot of times, when we want to get a medication covered, we have to show that patients have tried lifestyle intervention, right? We have to check a box that says, well, they tried lifestyle first, right? Well, it's only effective 10% of the time. It's only effective 5 to 10% of the time. Like, why would we stand for such a treatment?
Right.
If your disease is bad enough that you have a drug that's effective 40% of the time, or a surgery that's effective 70% of the time, like, we wouldn't make people do a treatment that's effective 10% of the time if it was cancer.
Right.
And granted, people aren't going to, from our obesity, we usually don't, have immediate, health issues that are life threatening immediately, like cancer is, right, from a life expectancy standpoint. But at the same time, we shouldn't have to like try these things for long periods of time in order to sort of prove if we're successful or not, if we're a responder, right? Because we know for any treatment intervention, there are responders and there are non-responders, and it's not the person's fault that they're a non-responder to their chemotherapy. But unfortunately, in weight management, we do tend to still, we got to get past that stigma and bias and be like, this is a disease process, and there are ways of making it better. There are treatments that can make it better, but we need to get much better access for people so that they can actually, get a hold of treatment.
Yeah, exactly. And like you said, it's like so many other medical conditions. And if we compare it to something like type 2 diabetes, we know that lifestyle is an important factor in the management of type 2 diabetes. And yet we see that about 86% of patients who have type 2 diabetes are also being treated with some kind of pharmacotherapy, compared to maybe 1 or 2% of patients with obesity that are being treated with some kind of pharmacotherapy as an adjunct to lifestyle changes. So yeah, there's just so many comparisons with other different chronic diseases where it's like, we need to start really letting go of the weight bias and stigma that this is just a matter of willpower or something that somebody has control over. We know that weight and appetite are highly regulated in the brain. And so I'm just so grateful to everything that you do to educate people. As the president of the Obesity Medicine Association, you've had such a massive impact. So to wrap it up, are there some tips that you might be able to give our listeners for those who are interested in learning more about obesity medicine? Where can they go to learn more? And also, where can they learn more about you or find ways to contact you or follow you?
Yeah, so that's a fabulous intro to our Obesity Medicine Association, right? Which we are so grateful for you, Karli, and all that you've done, for our organization and all of our members, what all of our members have done, because we're a very much a very active association, and I think it is our membership that makes us what we are, right? The coming together of everyone and sharing ideas, and especially in a field where a lot of stuff is still unknown, right? We're still in sort of a research stage of understanding a lot of the complexities of human metabolism and how to sort of how to adjust that, right? How to hack that, how to change that, to our advantage from a weight perspective. So the Obesity Medicine Association, again, for which I'm president of, is something that I'm very much looking forward to leading over the next 18 months and that's one place. We have a great academy where we have lots of recorded online CME quality talks. There's free webinars. There's our conferences that happen twice a year in the spring and in the fall. And I think that's a great way to just go and meet people and go and network. I learned a lot of what I learned from other people, right? And I think we still do that even today, even when we have so much technology, right? We still learn so much from this type of thing, from a podcast, from a meeting with somebody, right? An interaction with somebody, and learning from our patients, right? The Obesity Action Coalition is the patient advocacy arm of everything having to do with patients of larger size and patients with obesity. And so again, there's a way to educate, through that channel also. And so there's a lot of good education, to be had. And I think just, like I did back in the early 2000s, right? It's all about just getting out there and learning about things. We actually at the Massachusetts General Hospital have, and other places in the country, have fellowships now. So for those clinicians that are in training and they're considering obesity medicine, they can now do a year-long fellowship to really be immersed in a clinic that's seeing patients, with obesity day in, day out, right? That's what we do all day, every day. And we try to, share that education, with others via that fellowship experience, right? So I think it is highly valuable for people that have the interest in it and really want to advance their skill set, because there really is, something to be said for sort of hands-on learning, that you get from just sort of rolling up your sleeves and diving in, right? And learning from the patients, right? Because our patients are really the biggest source that we have, I think, too, of learning for sure.
Absolutely. Well, thank you so much. You're such a wealth of knowledge, and thank you for everything that you do and for being the first guest on our podcast.
I'm so excited. I forgot to say, for people to follow me, you can certainly follow me. I'm on all of the social media, Dr. Angela Fitch, on Twitter and Instagram and other places. So feel free to jump on there and keep in touch, because it is a good way to interact, right? By keeping in touch with others and getting advice from other people.
Absolutely. And we'll be sure to put all of that in the show notes. So thank you so much for coming on, and I look forward to seeing you at the next OMA conference.
Yeah, me too. I'm looking forward to it.
Thank you so much for joining us on the Gaining Health podcast. Don't forget to review and subscribe. And if you really liked it, consider supporting us on Patreon. Lastly, if you need resources and tools to help you start an obesity management program, be sure to check out gaininghealth.com. Thank you, and we'll see you next time on the Gaining Health podcast.